wasn't quite the place. Dentistsofinsta, they finally joined us. It's good to see you guys, right? I was starting this all by myself, really. So I'm sure if you send me a request to go live with Dentistsofinsta, add for you guys.
Hey man, sorry about that.
No trouble, no trouble. How you guys doing? You guys all right?
Yeah, good. Yeah.
So
How
I
are
just
you?
took I just took the liberty to just start it myself. I hope you don't mind, but
No, it was prayer time, so I just
yeah,
got
yeah.
delayed.
Yeah, I had to do mine before obviously we started.
Yeah,
Yeah.
awesome. All right, let me turn my PC on. How have you been doing? You okay?
Yeah, very well, very well. Doing the best that we can in these times. I was just
Sure.
giving a little intro to Hi Polydenti. I hope you're well. Tom Bryan, I hope you're good. It's been a long time. Hope everything's going well. Yeah, no, just really using this this opportunity to really focus on ourselves and focus on what
Yeah,
you want to grow. How I think this is a great time for planning, isn't it? You know, when we've got forced into a circumstance that isn't inverted commas ideal, it allows you to plan and grow for the way you want to go forward. Hi, Hawa, hope you're
yeah,
well. Hi, Dr Khan, hey, Mavanatis. But yeah, I suppose like everything, you focus your time on how you can optimize what's going forward. So, hi, Alaland.
yeah. No, for sure. I've been doing a lot of the Instagram at the moment. So since we kind of went on the lockdown,
Yeah,
uh, getting in touch with a lot of people, being able to kind of pick up some tips that I was wanting to kind of get out of things beforehand. And now I'm
yeah,
at that point where actually I've got all this time to reflect on the work I've been doing,
right,
and
exactly.
and then hopefully when we eventually go back, step it up.
Yeah. I think that's what this time is really useful. And often we don't get that time. We don't get enough time to sit there and
Mm,
reflect on these things. So getting the opportunity to do this now is it's a blessing in itself. I mean, there's a lot of other issues going on in life, right? So
yeah,
we have to be thankful that we're all in good health, etc. But I think the main thing is to remember that ultimately out of this situation, so long as you're staying home, staying safe, what can we do to optimize ourselves? What can we do to give back? Hence why I've decided to join you on this Insta Live. So
yeah, sure. Right. So we kind of had a little chat beforehand, didn't we? We said, okay,
yeah,
we'll look at some cases and things like that, so that we can all kind of take something away from it and a step by step sort of away. And there we go. There we are. So I'll field any questions,
yeah,
and if you want to go through the case as we go step by step. We did this with Gil last night, and it worked down really well. A lot of these guys were joining us yesterday. I know Howard was there and a few others.
yeah. I just got to say thanks, Howard, for the compliment. You've got to be an advert, isn't it? So you have to do the work as best you can. Hi, Rena. I hope you're well.
Yeah, and Rena yesterday as well. So if
Yeah,
anyone hasn't already joined up to Rena's Perio email series, for sure, have a little look at her Rena RW Perios page and sign up to the lecture series there, which is completely free. Definitely worth it these times. So,
good. So I think the way that I started this off anyway was to talk about. No, I haven't had any cosmetic work done, only ortho. All right, so there's no. This is all a natural, yeah. So yeah, yeah. What I started to talk about with the other guys was basically the journey that you take when you want to start in this sort of facet within dentistry. Obviously, we know that dentistry is very large. Obviously, we
mm-hmm.
know that you can take a number of pathways to get to your end goal, whether that's dentistry, whether that's life. But I think one of the major things that was quite clear to me from the outset when I qualified was I really enjoyed composite type stuff and making things look natural. I think the idea of trying to
Yeah,
recreate nature is something that we'll never really truly achieve, but we can get as close as we can. And that challenge really excited me. So taking the time to do adequate courses, learn from people that have already been there,
yeah,
was really a key facet of my development and going forwards. I think the main thing that you need to realize is you can do only a certain number of courses up until which, hi Faraz, hope you're well. Hi Anaya, hope all is good. Hi Haroon. I think you can do a number of courses, but what happens is there starts being a translational problem whereby you can do it on a model, and then you can't quite get that repetition or reproducibility within a clinical case. But that's where clinical photography comes in ideal. So like you said, you're taking the time to reflect on cases. That's fantastic, because actually you can see, right, this was okay, I could have improved it here. And the go home message from me to everyone here today is the first thing you need to do during the lockdown period, if you haven't got a camera, get one. If you've got a camera, you've got photos, go through the whole library, because that's going to be your opportunity for the richest learning, because it's your learning, you know. So
yeah,
I think that's really important.
Yeah, that's something that the guys who've joined us previously, I've probably said 5 or 6 times on these lives. The first thing I did was I bought a camera, the twin flash or a ring flash, whatever it is, macro lens. Take photos the whole way through your FD year, or your first couple of years of practice if you're abroad. Then when you go home, you can see exactly what you did.
Yeah.
In an environment where it's you're stress-free, you're not actually having the patient in the room now.
No.
And you can be as critical as you like out loud.
Yeah.
Which is something that I struggled with. I sometimes I would say, oh, that doesn't look amazing, and they'd almost hear it, and I was like, okay, no, it's fine. Yeah, oh, that's really good there, actually. Yeah, and
yeah. And I think that
critique it.
Honest reflection is the most important. Hi, Dr. Robles. We've got some US people joining in. Hi, Ilias. Hope you're well. I think the photography in a non-pressured environment is really important. And hi, Dr. Norman. Hi, Van der Kuken. Hi, Simon. I think one of the main things about all of this is you being really honest with yourself. And the more photos you take of each step within reason. I mean, you don't take 35 photos for a cavity prep. Fine. I totally understand that. But if you can take pre-opening of the cavity, cleaning of the cavity, for example, in a restoration, direct restoration, you can then start reflecting on, do you know what, I was probably a bit aggressive here. Or, do you know what, that line angle hasn't been quite rounded. And really the key for all of your growth as a clinician is open, honest reflection on your work, and send it to your peers. Hi, Marnori. Hi, Dr. Nukre. Hi, Nukre. Hope you're well. We've got Miami tuning in here as well. Hope you guys are good.
Loads of guys, yeah.
Yeah, Miami. I think the weather's better than in the UK. Yes. If you can be open about the way your cavity looks, or how you've prepped, or how you've done the anatomy, or how you've done that distal reduction, whatever it might be. That's, I think, end of the line, because you'll never be happy. I don't know about you, but I'm never happy. There's always something I can criticize about anything I've done, and don't get me wrong, I don't think I'm perfect, but I think that strive for as close to nature as possible, that will only come from reflection.
There was someone who said, I can't remember if this is just like from a film or something, it was like, oh, the minute you think you're brilliant is the day you've really screwed it up.
You're finished.
Yeah, it was something along those lines, and it's so true for dentistry.
I mean, I couldn't agree more. I mean, I've done some work which I was, I thought was reasonable. And actually, you just think to yourself, right, I could have done a lot better on this by doing this. If I'd moved this fossa here and moved this marginal ridge, like there's just like all the time, there's this. What it is constant pursuit of excellence that you almost never achieve, but accepting that you're never achieving it, you're just getting ebbing closer each step. I think that's the key for, well, at least clinical dentistry, probably communicative dentistry as well, and all that stuff. But I think in dentistry in general, or any facet of life actually, for that matter. So, yeah.
Should we dive into this case then?
Yeah, let's go for a case, guys. I think that would be quite fun. So I'm just going to change my camera.
I'll field any of the questions that come up down below. So
that'd be great.
Keep an eye on things.
Yeah, that'd be great. So, I mean, people know me a lot for sort of direct sort of work, and I thought that to create some variability, why don't we do some indirect related work? And the idea behind that is so that we can see that actually, whether you're trying to achieve aesthetics, however the case may be, so long as you are aiming for the same goals, you'll always create great outcomes. Now, I've deliberately kept the smile out of the patient's smile out of this because they've requested not to be the case. So I'm just going to readjust that. But here we have a patient who says, I don't like my crown. That's the presenting complaint. Now, hi, Hilaki, I hope you're well. Now, what's the situation here? Well, there's a couple of things going on, isn't there? We can see that the crown, the margin's probably slightly visible. Yeah. What else is the issue here? And I think
we've got a buccal corridor there that's kind of coming in a little bit on the right hand side.
collapsed buccal corridor on the right hand side. Absolutely. There's not sufficient canine overlap. There's quite a few, I mean, quite significant problems if you look into them well enough, right? So, you know, when you look at the patient's charting, actually they're reasonably unrestored. A couple of complex fillings, all that look well. He's got missing premolars and he's got missing 8. So he had his 8s removed, but the missing premolars implies that there was probably some ortho in the past, right? So, okay. Yeah. Hi, Bal. Hope you're well. Hi, JQ. Hi, Hap. Hi, Journey. That's the second time you guys are tuning in today, so thanks a lot for the support. So we have a look at the x-rays that we've taken, and actually...
Can we zoom in on that OPG?
Yeah, we can.
Let's do that.
Let's do that. Right, so we've got the OPG here, and there's obviously a reason why I took an OPG here, which will come, you know, indication for why you're doing these things is very, very important. But the key of the issue is really right there, isn't it? Yeah?
Hey, Val, how you doing?
Awesome. What is going on with that upper right one? Okay. Central, post-crown, RCT. Is that a residual periapical area? Yes or no? Is it something that could be resorption? Yes or no? Is it a reasonably well done root filling? Yeah, I think so. What's that space, the void between the root filling and the post? Maybe it's probably GIC. You know, there's a number of things it could be. Maybe it's the post come loose. That's why all of this. And if you look really, really closely, you can just start seeing that the margin looks like it's just coming away there slightly.
Easily.
Yeah. So is that the margin of the post? Is that the margin of the crown? Now, all of this starts adding questions that we need to answer in order to get to the right treatment plan. Does that make sense? And making sure that you have adequately collected all the information, I think, is so important, because if you're not collecting the right information, you can't appropriately plan. If you're not appropriately planning, you're going to fall short because something's not going to work out. So I think getting all of this information is really important. Now, why do you think we took the OPG? Well, it's quite clear, because we were thinking about those collapsed buccal corridors. Actually, as soon as we've seen this patient, we'd sent them to the orthodontist, because that collapsed buccal corridor is probably part of the problem. But we've got another issue here. If we're talking about purely aesthetics, we've got asymmetric gingival levels. Yeah. Why is that? Well, is that because the upper left one has worn down? Possibly. Is that because there's been over eruption? Don't know. The other significant thing here is on the right hand side, I don't feel like there's significant canine overlap. So when they're going to go on excursions right and left, they might not necessarily be using that canine. And what I want
looks a little clear. There's like a little gap. Yeah.
So when they're going to guide left and right, we start seeing that there's potential. Sorry about that, guys. There's potential problems. Okay. So whilst I know that this upper right one has got a post crown, is the prognosis good or bad? We don't know. We'll have to assess that when we take it off. But if we choose to restore or we choose to remove, the idea is whatever's going to go in that place, we don't want any excursive loads on it. So again, right from the outset, you're starting to plan for the longer term, the long game. And if you don't have these things in the pipeline from beforehand, well, actually, you're just setting yourself up for failure. It's very easy to turn around and say to yourself, right, we'll just change that crown. Well, if you ask me, to change that crown and get a better result by itself, it's very, very difficult to do, because
not with the other side doesn't look great either if you're looking at an aesthetic result.
Yeah, exactly.
There's other factors, the marginal kind of equilibrium.
And what are you going to do? Are you going to try and make this shorter to make this look like this? I mean, what's the choice here? And if you start making this tooth look similar in shape, and the proportions of this tooth are incorrect anyway, this is looking more square and ovoid rather than it is rectangular. So we have to start planning these things in advance. So if you look into this case in a bit more detail, you start seeing a few more things. You start seeing that there's a tooth width discrepancy between the upper centrals, right? That's going to be the first thing that's going to create an issue, because two asimilar central incisors is always going to appear quite apparent. The only other thing that appears more apparent is a cant in the center line. The other thing is we've got gingival height issues. We've actually got tooth height issues, which are different as well. I'd say that the buccal corridor is an issue. The canines haven't got significant overlap on the right-hand side, but also the color of the teeth. The color of the teeth have been matched, or the crown has been matched to the color of the teeth when all this work was done. Has the patient had a discussion about whitening? Yeah, I have, but the problem is I'm not sure if I can do that because the crown's not changed and the teeth will go up and the crown doesn't. Yeah, absolutely. The dentist who's had that discussion is absolutely right. But if we're going through the changing of this crown, if you don't have the discussion about whitening, you're doing this patient injustice, aren't you?
Yeah.
Because frankly, this is the perfect opportunity to change the color. So again, just making sure you've got adequate consent by talking about all the processes, all of the procedures, all of the options is really, really important, because if you don't have these discussions, this is when we start getting ourselves into trouble, right? Oh,
Absolutely.
they didn't tell me I could have whitening. Well, I'd argue if you didn't have any whitening or any discussions about orthodontics here, you're doing the patient an injustice. And I think this is why we have to take this holistic view rather than just saying, right, you want to change a crown, this is how we do it. I do understand that there are limitations within the health system to try and plan for these things. I totally understand that. And
Let's
sometimes
approach it from that view of a gold standard dentistry, because I know there are people from across the world watching, so we'll try not to like peg ourselves on the NHS, for example, for this case. And also, if anyone's got questions for Dr. Shiraz, please do drop them in the comments, and we'll field those.
And just to again make this super clear, there's no bash on the health system at all.
No.
The system is driven for function, it's not driven for aesthetics. So when a patient comes with an aesthetic problem, we have to deal with that as an aesthetic problem, not a system that drives the way you deliver care, if that makes sense. So
no,
yeah,
it's a different system. Yeah.
just to make it clear, I love the NHS. Absolutely 100%. All right, we'll get back to it now. So moving on nicely. So when we start talking about ideal tooth proportions, we can start seeing actually the upper left, the upper right one is not a million miles off from the ideal proportion.
No.
And again, having this is the great thing about photography. I have almost got to the end of my treatment plan before I even done anything with the patient. They've come in for one appointment, they're going off for an SMP, they're going off for an appointment with the orthodontist, and I've already understood what I think is likely to be the outcome that I'd like to improve to. So from this, what we can understand is that the patient's upper right one is not too dissimilar from ideal proportions, but you can see how much that tooth width discrepancy affects the appearance of the smile, etc.
And what system of what system of or software have you used for that?
So this is just
overlay?
routine digital smile design. So the software that's quite readily available to everyone. It allows you to give you these, these overlays over photos, which are pre-designed and prefabricated. And the great thing about it is it also gives you different shapes of teeth in reference to different shaped faces, etc. The only disadvantage I would say of all of DSD is, and there aren't very many, is that with DSD you have this situation where you might have a patient who's got lovely looking teeth, but they don't fit the golden proportion. And I think the disadvantage of this system, or trying to give this golden proportion to everyone, is, well, actually, there's a lot of people that have a great proportion without golden proportion. So whilst it's a fantastic system, just remember everything, it's a tool. It's a tool for us to try and make a diagnosis, a plan to go forwards.
Absolutely.
So
current question there, is it available on iPad?
Yeah, you can. Yeah, you can. So they've actually got an app. Hi, Kyron, I hope you're well. There's actually an app, so you can take the photo within the software, and then you can overlay all these things directly on your iPad. So it's fantastic. Great use of modern technology. So we had my specialist orthodontist who did some lingual orthodontics. Okay, the patient didn't want it being visible to anyone. So this is the preoperative situation.
Yeah.
And this is what we got to post ortho. And
So
now
sorted out the right hand side there.
That's correct. So we created a more appropriate buccal corridor. We've probably tried to create a bit more canine overlap with the adjacent canine. Yeah, not with the premolar, with the the opposing canine. There's more overlap, so there's a significant chance this is guiding more, which incidentally it was after the ortho. More importantly, we've created a bit of restorative space between these tooth. Now, the discussion then is, how are we going to treat that? We'll go through that in a minute. But also, gingival levels have been sort of equalized as best as possible.
Yeah, they're much closer now. Yeah.
So now we're in a situation where we've got this blank canvas. The orthodontist has done their part of the game to improve things as best as we can. What do we do now? Now, I think the main hit point here is discussion of options, because what do we do? Do we go direct? Do we go indirect? Hi, Amin, I hope you're well. Do we go direct? Do we go indirect? Do we, if you are going to place composite, and this is the real challenge of this case, if you are going to place composite, and let's zoom in on that upper right one, if you can see that incisal edge, that is incredibly difficult to mask. Now, it's not difficult to mask, it's just going to be a challenge. The other thing is what's going to be the difference in longevity in your restoration and if it's direct and it's indirect. But more importantly, and I think this is the key of all of this, if you place composite onto the incisal edge in that area,
Yep.
you're not correcting one thing, are you? You're not correcting the tooth width discrepancy between the two centrals. And I think this is where you give, again, you re-deliver options to the patient and you turn around and say to them, look, we've got two options for this goal. We can either accept the tooth width discrepancy and try and play with the line angles with the composite. We can stick a composite bonding onto the incisal edge only. So incisal edge bonding. We can do a composite veneer and play with the line angles so that we can make it appear more slender, inverted commas. Hi, Dental Jim, hope you are. Hi, Rena, hope you're well. Or we can turn around and make the decision to go indirect on that tooth as well. Now, what would be, just let's have a discussion together. What would be your input to that? Why would you consider direct over indirect? Why would you consider incisal edge bonding over composite veneer? Why would you consider composite veneer over incisal edge bonding? Go for it. Tell me your thoughts.
So I always start kind of with the least invasive or least work needing doing, and I kind of put that foot forward first if I'm going through a case like this. So I'd say, look, you've got the option of edge bonding. It's much less of an addition onto the tooth. We're only going to be lengthening, in this case, the tooth. It's not going to make it thinner. The plus side of that is we're not covering the whole surface. So obviously we know that if we remove a composite veneer, we will be touching tooth. So it's not an irreversible procedure. And edge bonding is much more conservative in that way. However, that's probably the least aesthetic of the three results that we're going to get.
So my question to you is edge bonding an irreversible procedure?
I would say these are all irreversible procedures. Because the minute we bond onto the tooth or we've etched the tooth, it's changed that surface forever.
That's it. And I don't know how much experience the viewers or the yourself have with removal of composite. I can guarantee you, even if I'm using a slow handpiece, tungsten carbide burr, multi-fluted to remove composite only, I know I'm going to get absolutely up to 15, 20, maybe even 30 microns of enamel damage. In removing that composite. That's purely not fast handpiece. That's not going with a shotgun and trying to take all of the composite off. That's really going as minimally as you can, and you're still. And the fact is as soon as you've done the bonding, you've invaded the enamel prisms. You've invaded it. You have to remove the aprismatic structure to get effective bond. So enamel is made up of aprismatic enamel and prismatic enamel. Prismatic enamel is stronger to bond to. So when you've etched the surface, or if you aerobrade, which is really the gold standard, what you're trying to do is remove that aprismatic enamel. So you've got a stronger bonding substrate.
Going to make the micro tags and all those.
Absolutely. So you've just compromised the tooth surface. So I think what we have to, no procedure is non-invasive. I mean, even the scale and polish with the wrong settings on your hand scaler can be on your, hi, Institute from Romania. Hope you're well. Sorry, I'm off topic. No, all good. It's all good. Even with an ultrasonic scaler, you can create enamel damage. So the fact is, anything we do, high sodium dental, anything we do is invariably going to affect the enamel. Okay, so let's go back to the case. Sorry, that was oh no, you haven't quite finished, have you? Actually,
that was option one.
Yeah.
The option two was your composite veneer. So we're more likely to be able to give you an aesthetic result with that. However, that is now turning into I would say a cycle of restorative treatment on that tooth. That I say all of these things are likely to fail at some point. The edge bonding is going to be the first thing to fail. Your veneer is next. And then if we go indirect, that's the most likely to last the longest. However, we are going to be taking some tooth away from you. And then there's the ramifications of, pulpal health, and then everything that goes along with that, possibly losing the tooth in 20, 30 years. So there are a lot of considerations there, and you need to make sure that patient kind of understands all three and knows where they're going. So I would say, even if you're going to start with an edge bonding,
HS, HSB, apologies. HSB, I'll get you that Armani brick, bro. No worries. These are people I went to dental school with, so absolute joke.
We
So,
we
hope
do
you're
need
well.
to talk about your dress sense, because I messaged you before my cousin's wedding. I don't know if you
All
remember
right.
that.
Oh
Uh,
yeah, was that you? Oh no
yeah.
way, no way. Oh my gosh.
And I was
No
like,
my.
bro,
Oh.
what color pocket square shall I buy?
A really dire clinical needing question, you know. It was like, no, this is really important. Oh man, yeah, we'll get to that in the
Yeah.
at the end of it.
And you know, it went well. Put it that way.
I hope so. I hope my advice was reasonable.
Yeah. So
Yeah.
my mum wasn't happy with it. I'll just digress a little bit here. But my cousin's wife's mum absolutely loved it. She was like, "Oh my god, his stress sense is so good."
Oh, do you know what? Do you know what? I mean, apologize to your mother in advance from me. Tell her I'm a nice man. All right.
She's
So
probably watching. To be fair, she watches all of these.
yeah, she's like, is it him? He's the guy, right? I'm gonna get his Instagram and I'm gonna send him some hate mail. So, oh, Slava Kwan if you're watching anyway. Yeah, no. So back to the topic at hand,
Yeah.
obviously. Go for it.
Yes,
Are
and
you feeling like that?
obviously that's kind of me wrapping up. Then you've got all those particular pros and cons. I would say that even doing a composite edge bonding case, you're probably sending that patient on, 5 to 7 years down the line.
Absolutely.
They're probably going to want a veneer next, whether that's composite or an indirect. And then 10 years down the line, you might be doing a full crown because that's failed. And then it might devitalize, and then you're looking at possibly replacing that tooth with a bridge or an implant. So you need to be aware of these things if you are going to be offering that.
And
That's the biggest thing I would say.
I think one of the things that you're talking about, this is where communication is really important, because if you and I reeled off those list of options, it almost sounds semi-defensive, doesn't it? It almost sounds like we're trying to say to you, anything we do is going to go wrong and it's going to be an issue and it's going to be a problem. And what we're trying to do is we're obviously trying to not encourage treatment. We're trying to furnish the patient with the options, with the relative merits and pitfalls. That's the key. You give an account of the pitfalls, you give account of the merits, what the options are. And hey, how you doing, Reed Feluccio? Hope you're well. We've got Portugal tuning in as well. So the process in my mind was very, very simple. It's like, look, we've got 3 or 4 options. These are all of them. And what I do have a discussion about is if you wanted ideal optimal aesthetics. Yeah, because he's come as an aesthetic patient, right? He wants to improve his crown or smile or whatever. What would we do? Hi, Dr. Sadfi, I hope you're well. What would we do? And in that circumstance, it's very, very clear. It's like, well, to get the best match and to correct the tooth width discrepancy, indirect is absolutely required.
100%.
Because you require slenderizing of the adjacent tooth. Now, if you're willing, now the discussion then is, are you willing to accept the tooth width difference between the 2 teeth? If he's like, look, I don't really care, I just want them to look better, well, then actually composite bonding probably starts being a more attractive option. However, in this case, the patient was clear. They were like, I want as optimal or as ideal aesthetics as possible. So in that discussion process, it's very, very clear which way we go. Now, the problem we have then is the restorative choice or issue.
Yeah.
What happens when we take that crown off?
Just backtracking slightly,
on
the side of giving that patient the reeling off of the pros and cons and the possible sequelae of treatment. Sometimes I'll say, especially with a root canal, look, I've got to give you the paracetamol packet slip now. These are all the things that I have to say out loud that you would normally read and think. That's normally how I go through that. So I don't know if any of you guys are wanting to do certain treatment like that. Just maybe soften the blow, saying, look, because I'm doing this treatment with my hands, I can't give you a little slip and go, oh yeah, read that later and think about the contraindications and all that sort of thing. So I'd say that out loud. And I'd say
the way I talk about this is really, really simple. It's like, look, with any procedure, there's always going to be a set of risks, a set of benefits, a set of negatives. And what we need to talk about is outweigh those negatives and positives for you, because those negatives and positives change from person to person. So I'm going to talk to you about what we can do here. I'm going to talk to them about the options, and then they're going to be able to take that away with some photos, with a letter, make some decision on the plans, have another discussion, treatment coordinator myself, whatever is required, so that we're keeping informed consent all the way through. Because, like you said, if you give it on a piece of paper, it's probably toilet paper, because there's a shortage of that anyway, right? So let's face it, it's always going to be as important to the person that's going through it. There's some people that come back, they're like, oh, you missed a comma. And I was like, whoa, you really went to town on reading that. That's great. I mean, it's really, really important. You need to make sure it's as perfect as possible all the time. But ensuring that the patient has got informed consent with the appropriate negatives and positive is a key aspect of the GDC's guidelines. That's the General Dental Council in the UK, but any informed consent wherever you are in the world. So yeah, I think that's really, really important. But again, the idea is we're not talking about trying to talk them out of treatment. And I think being a relatively young, not so young anymore, but reasonably recently qualified clinician, this is the struggle you have. We have to talk about the negatives. We are all worried about getting sued. We are all worried about any treatment we do not lasting, being problems, and etc. But at the end of the day, they have come to us to solve their problem. If there are unforeseen circumstances, we need to have plan B, C, D, E, F, sure. And a part of this discussion was actually, and I'll go back to the case, is I have no idea what the state of the tooth is underneath that crown. I don't know. I don't know if there's a root fracture. I don't know if the post is done. I don't know if there's a periapical radiolucency, or that's just a residual bit of scar tissue that I showed you on the PA. And the thing is having that discussion with the patient beforehand allows to open the discussion for what's called a restorative appointment, right? So where we take the crown off. We just assess, right?
We're going fishing.
Yeah, basically. We go fishing. We need to see what we can find. Is the post wobbly? Am I going to replace that post? Is it really well seated? If I try and remove that post, is it going to fracture the root? In which case we would leave the post alone. There's all these decisions that need to come in, and that's going to finalize the pathway that we take at the end. So this restorative appointment is really based on trying to understand where we are. So you could see from the x-ray already that we were pretty, well, I say pretty stuffed. There was a metallic post underneath there, and you can tell by that margin that this is a PFM. So they've been able to mask it with using metal underneath. Now, if we whiten teeth, what's going to happen then? So we'll go through the next steps of the case, and that's what we've got underneath. So we did the whitening, and we've got this post underneath, right? Now
Let's zoom in on that post, please.
Yeah.
So we can see in there.
So
hope
that
you guys will see that at home. Awesome.
Right. So that post is as juicy as the day it was done. Right, it is looking fab. There was no leakage. I did go around the margins. I tried to try and, ultrasonic or any, just to see if there was any movement. It was absolutely perfect. Now we have started to create an issue, because we have prepared and slenderized the adjacent tooth. And I think the next picture should show that I kept 0.3 millimeters. It's all in enamel. So I can zoom in on that if you like. So that's awesome. 0.3 millimeters in the cervical edge. And that's to remain as minimally invasive as possible, right? And the idea behind that is, well, I want to correct that tooth width discrepancy. We want to try and improve the appearance of the whole smile, not just the crown. So that was a challenge, but we got there in the end. And this is how you start getting into things in a bit more detail. This is the shade map that I did. No, that's a lie. I didn't do the shade map. That's from the tech. That's from the technician. So I'll give a shout out to Luke Barnett, because he did this absolutely glorious job on this case. And what that does is it starts us understanding how complicated this case really is, right? This is not a 2-minute case. This is not going to be like, one try and boom, we're done. So anyway, we did some temporaries. And and this is where I'm showing actually a failure, okay? I did my temporaries. I was like, it should be all fine. Was it really too? Yeah, it looks all right. I mean, I think it looks quite balanced compared to the two. And guess what? Loss of papilla. Loss of papilla. So what had happened? So this is what's called the biscuit bake stage. So where I've got the morphology made to appropriate. We've done the shading to as good as we can. And I'm trying to seat the restoration to see if the margin fit is good. And the problem is, because I had an overhang in the interproximal area, I didn't clear it properly. I've caused recession in the interproximal pillar. Now, there's very, very clear evidence that shows that if that papilla is within 5 millimeters of the alveolar crest, we're going to get papillary infill. The point I have to make about that is, why are we going to take the chance? Why are we going to take the chance? And here I'm showing you, I deliberately chose this case because it didn't go perfectly, actually.
Yeah.
Even the end result, it's pretty good. The patient was over the moon, but it's still not perfect for me. And I think people will learn more from the imperfection of the case rather than me being like, oh my God, yeah, Ray, this is amazing. You're amazing, Shiraz. That's not what this is about. This is about learning experience for everyone. And if I had corrected the papilla, we would have probably been in a much better position for the temperature. So this the learning point at this stage is temporaries are everything. Temporaries are absolutely everything. If you can treat your temporary as if it's your final, you're not going to get this situation that is in front of you there. All right. So we've done biscuit bake. Everyone's quite happy. Now, obviously, the bonding protocol for you've got a number of interfaces here. You've got dentine, you've got metal, you've got enamel, and you've got ceramic.
Ceramics,
and I don't really want to go too in depth about the bonding procedure because then the whole time will run out for the Instagram Live.
Yeah.
But I'm going to be doing a couple of other webinars, and one of them is going to be about bonding to different substrates. So hopefully you guys can tune in for that. But the idea here is we've got an etchable ceramic, we've got Emax, and it was Luke's idea to do both as Emax. I actually asked for the there to be a zirconia coping over the metallic, so completely opaque, and for it to be layered over the top, and then Emax on the veneer. He said to me, Shiraz, I'm really confident that I can get a great result with just Emax for both. I've got great blockouts, so I think I can get a great result. I was like, all right, do you know what? I totally trust you. And, we got a really, really, a reasonable result. The patient was over the moon. But I think if we had done that as a zirconia coping to block out the post, we would have had a better result. Anyway, rest assured, we learn from these things, isn't it? And so just to be clear, if you're going to etch feldspathic or lithium to silicate, you need to use a hydrofluoric acid etch. You can use the phosphoric etch afterwards. The only real advantage of that is to remove any over etching areas. The other gold standard that people suggest is that you can use an ultra. And sorry about that, my battery's running out. You can use 99% ethanol, and the idea behind that is to remove any of the porcelain salts and put it in an ultrasonic bath. Okay. Hi, Dr. Oral Health. Hope you well. So once you've done that, you need to silinate, and then you do your routine etch and bond procedure on the tooth. So this was the pre-op, and that was post-op.
Yeah, brilliant.
Right now, the thing that I don't know if you can see it on the picture. The thing that the patient is absolutely over. I mean, that was pre, right? And that's post. The patient is absolutely over the moon. The problem that I have, and I don't think you can see it a little bit. There's just a little bit of a blue hue around this tooth.
It's very hard to tell whether it's just the lighting or
yeah. I mean, it is a bit of lighting, but I myself will also say that it was actually a blue hue around the tooth. And what that was just at the extremities, there wasn't enough block out. So what that's doing is just creating the blue hue from the metallic post. Now, I said to the patient when I did the trying, I was like, look, I really think I can get this a little bit better. He's like, no way. He's like, no way. No, I'm not having it. He's like, I waited 2 years for this, and this looks better than I ever could imagine. So then we're in a situation where you're like, okay, am I doing this for me? Or am I doing it for the patient? Ultimately, we're doing it for the patient. The patient was over the moon, and yeah, they were happy. But you can see the difference. I mean, we've really transformed the smile there, and the patient is just absolutely ecstatic about the whole procedure. He's had a great experience within dentistry. So that was one case.
Awesome.
We've got time for one other case, yeah?
Yeah, 15 minutes we've got, I think, before
we... perfect. Yeah, before it starts kicking us off. Now, I wanted to show you some composite, because obviously everyone knows about composite. Everyone knows that composite's a fantastic tool for us to use these days. And actually, a lot of the time it can be the material of choice. Well, thank you very much, A Dental Journey. Thanks, Dental Jim. Hope you're well. Hope you're doing some press-ups while you're watching the video. Dr. Kalpesh as well. I obviously do a lot of composite work, and I think one thing that was really important to me here is trying to show you the replacement event. So me and Tiff are doing, so guys, for those that are here, me and Tiff are doing a webinar tomorrow, and it's called Everything About the Ortho Restorative Interface, and we're really going to be talking about this whole replacement event and so on. And I think this is a really, it's going to be an Instagram Live. So me and Tiff, same setup as we've got today. Please tune in and enjoy it if you can get some open access learning for obviously for free, and it's all about a community here. Yeah? So this really for me summarizes the whole replacement event, because it's very, very difficult. So I'll just get onto the case. So this is a patient who comes in, and this is a very, very difficult case, okay? And there's a reason for that. This patient, whether it was right or wrong, I think we can go into that another day, had composite veneers at the age of 16, okay? She's now 25, so it's 9 years down the line, okay? Yes. I think they've done really well. In fact, I'd still argue that they still look pretty good. I mean, yeah, we're getting some margin discoloration, but there's a little clue there in a minute, which we'll go into in a sec. But actually, they look really, really nice. And the presenting complaint from the patient was, I don't like how they look. I just, you know, they're starting to stain. They're looking a bit rough and rugged. I want to have them replaced. So again, discussion of options, and we can go through that on another. We'll do another one together if that's right.
Yeah,
We've got loads that we can talk about. So
I'm doing 2 a day, so let's do it.
Yeah, I mean the thing is invariably, you know, we can keep going. We're already running out of time. We've only done one case. I had 5 lined up, but anyway. The main thing to say here is you can direct, indirect, ortho, and then edge bonding. These are the options. Patient was absolutely adamant that she didn't want ortho. Okay, so we've got through that part. Let's go through the next stage. So we take some photos, and again, when I put these on the screen, the patient's telling me what she doesn't like. She's like, oh, that canine looks ghastly. I'm not happy with how the staining is around those composites. How can I improve all these things? Hi, always hope you're well. How can we do these things? Now, this for me, I think is a very, very important view. It's the retracted and contrasted view, because it gives us an idea of where the incisal edges are, where she's got some chipping.
Can we move out from that one? Or is that the picture?
That's the whole picture there. So
perfect, yeah.
Yeah. So it gives us a lot of information. And I like going close up as well, because then we can start seeing maybe a little clue there, maybe of what's going on. The other thing that she didn't realize, but you can only start telling when you see the photos, is can you see the centerline cant?
From the left to the right.
No, actually, it's from the right, upper right one to the upper left. This is slightly non-central. It's just 0.5 degrees canted. Now, that's not an issue because no one else can tell. However, that's an issue for me because I need to understand how to improve that, right? So again, photos are really key. And here's where the real clue comes in. Let's go up there.
You can already see it, yeah.
Yeah. So we have got secondary caries behind the composite veneer because of this overbuilt margin. And what's happening is she's finding it difficult to floss. The floss is catching, food is getting impacted, and it's been doing so for 9 years. That's the issue. So now this has gone from aesthetic standpoint totally to become biomechanical and functional. So how are we now going to improve this patient's smile? But also we need to get rid of the decay. How deep does that decay go? Is it really deep? Is there any need for any liners or base or whatever? And that's again another webinar that I'm going to go through, whether we need to do things like that. But what's the situation there? What are we going to choose to do? And I think what the main point about all of this is, so long as you have a clear discussion with the patient about the options before, look, I don't know what we're going to find once we take this off. We don't know how far they've drilled into the tooth because you can't tell that from a PA. We don't know how deep that decay goes. The PA that we took of the tooth only gives us a part example of how far it goes. Hi, Valentina, I hope you're well. It only gives us a part of the picture. The only way we're really going to know about this is when we get in there. Okay, fine. She understood the risk that endo could be a risk of this, and we'll make a plan going forwards. The patient was happy with that. So, done some whitening. And do you know what? You say teeth don't, composite doesn't whiten, they don't, but they got whiter. I did, whenever I do these cases, I always do literally as the patient's walked in, before they've even got the chance to be nervous, I want to do a pre-composite trying. Now we can see that there's 2 shades there, one slightly darker than the tooth, one slightly lighter than the tooth. So I realized that we're probably going to use a blending process for that to be near the cervical and this to be near the incisal. Again, just giving us an understanding of how we're going to do this. So this is when you start removing the composite, yeah?
We can see it there and that. Yeah.
Right. You know there's caries there. You and I both know there's absolutely caries there. Is there something there? Don't know. Maybe it's just translucency. Now, my question to you is, how do you know you're in composite?
You don't.
Right.
When you look at that, you don't.
You have absolutely no idea. You're sitting there wondering, have I just gouged that person's tooth?
Actually, the point you know is when you're indenting, because it goes like yellow. You're like, okay, no, we're not.
Oh right, oops. Yeah, I've gone too far through. And I think the main point about all of this is and this is a really golden tip number. I don't know how many tips we've done, but this is a really important tip. If you blow that with air, the composite surface will look matte. The enamel surface will still look somewhat shiny. And what that does is it allows for you to then discern the difference. Which company composite do you use? Dr. Amitha, I'll tell you what, I use lots. I use lots. So I use 3M, I use Composite, which is from Style Italiano. I use Venus for some cases. I use Asteria. I use DMG, that I'm a key opinion leader for. I've helped design a composite for them, and they're fantastic. So if you want more information, I can certainly help you out with different composite systems and so on. I'm conscious of time, so I'm going to breeze over that quickly. So anyway, we've isolated with rubber dam, and now we're in a situation where, can you see it looks a bit more shiny? Now, it's not going to be completely shiny because it's etched.
No. Yeah.
Yeah. But this is the importance here. When you're doing composite veneers, I'd say that's quite well retracted rubber dam.
We need
When
more.
I use floss ligatures, look at the difference. Look at the difference that you're getting. And actually, if you're going to do a composite, no problem, Dr. Amitha. The problem that you've got is if you're not getting that level of retraction, your composite veneer is going to be short, and therefore the margin will be very, very discernible. Anyway, we've taken out the decay. Look how deep it was. Significantly more than we expected. So we've done the stages. What we're going to do is we're going to etch. Now, the way I recreate the proximal contours, if you don't have the Unica matrix, which is a fantastic matrix. So Polydentia are tuning in, guys. Polydentia are a fantastic company that make possibly the best anterior matrices that exists. It's a brainchild of the Style Italiano
Gurus,
black triangle, yeah, of dons in dentistry, I guess you can call it that. No problem, Polydentia, but they create, and I'll show you that in a minute because I've got a case to finish this off with. But if you don't have that, you can use a posterior matrix used longitudinally. And what I'm doing is I'm creating my dentine. So I'm trying to create some mamelons, trying to create some effects. I use composite brushes. So this is the Style Italiano brush that I use. It's fantastic. It's got interchangeable heads. And then we apply our composite increment in almost one composite layer in one increment. Okay. And that is what I call pre-polishing. That is pre-polishing. That's not even final polish. Now, the reason I do this...
That brush is amazing. It gives you the brush, because I don't think it's the same one you've got, but I've got a similar one. And it smooths out that surface really, really nicely before you end up curing. And then to polish afterwards is just, it's a breeze. Yeah, I mean, it just makes life a lot easier. There's so much less irregularities in the surface layer of the composite. So I do a pre-polish, and then I get them back in a week's time because I'm tired, they're tired. I probably can't realize what I'm doing properly, but I create the secondary anatomy and the grooves that I want, and then I leave them. I don't do any polishing. So this is really, well, I guess you can call it polishing, but it's like pre-finishing. So that's the day that she leaves the surgery. I get her back a week later, and now I can start seeing where I've got too many irregularities in the shapes or whatever. So I start going through things. I go through my polishing protocol, which I can go over with you maybe again. And this is post polish, right? So this is once the restorations have been done. And someone said to me, they're like, oh, did you lengthen the teeth because you've got incisal mamelons and translucency? No, I didn't. If you have an understanding of the shade system that you're using, you're able to recreate these incisal effects just by applications of different colors. And I think that's something. Thank you so much, Armand, dental student, Valentin Babek. I hope you're well. Diana. Yeah, the idea about this is you can play all sorts of these tricks with optical illusions, with different layers, different thicknesses, different opacities, and that will create this result. We had a chat with Hanan Imran on Tuesday last week. I don't know what day it was. I think it was Tuesday last week, and he was saying similar things. Polychromatic, it's underneath that final layer. You're going to add a few tints in here and there. That's going to shine through.
And the thing is this was done without tints. So this wasn't done with any additional. This was two various layers of opacity. And what that's created is this incisal translucency sort of appearance. So again, conscious of time, so I'm just going to press on. And that's the immediate finished polished surface. And I'm happy to zoom in for you to have a look. Gingival margins are healthy. Yeah, you can actually start seeing where the composite ends and the tooth starts. But you know what? That patient is absolutely over the moon. So that's the before and that's the after. Sorry, that's the before and that's the immediate post polish. That's the before and that's the after. And you can start seeing the difference in even characteristics that you can start seeing incisally. Because when you've got a final polish, there's more opportunity for light to play an effect. Pre, immediate post, post.
Big difference, especially between the second two of what you would think is a finish and then natural polish.
Yeah, exactly.
That was the matrix you were talking about, wasn't it?
This is the matrix we're talking about. So again, give a shout out. Thanks, Dr. Kalpisha. Thanks, Rena. Hope you're well. This is a quick case that I've just put together with a bit of music. Let's get the music up, shall we? So it's replacement of restorations. The material I used here was DMG. Get rid of the aprismatic enamel, air abrasion. I already had a diagnostic wax up. And here, etch, bond, create the palatal shells, which everyone knows about, which I do all the time. And that is matrix. It's called a unica. Perfectly formed, and it allows you to create perfect rounded line angles, as opposed to straight, which you would get with a mylar strip. Layer in the dentine. Put your enamel afterwards. Line angles are very, very important. You need to keep them as symmetric as possible. That was the pre-op. Do the polishing. That's post. And what you can see, that black triangle, I know that's going to go away because it wasn't there pre-op.
Yeah.
See? So that's just because I've used retraction. Immediate post.
That's where your wedge went in.
Yeah, that's where my wedge was. So that's going to go away. So.
Brilliant.
So, sorry for that. I guess it was a bit of a whistle-stop tour over a couple of cases.
That was quick, yeah, it's good.
I feel like there's so much more we could do, so much more we could talk about. But I think one of the things that I'd like to say is, I think what you're doing with Dentistsofinsta is fantastic. I think it's commendable to the profession to create open source learning like this. It's something that I'm working very, very hard on. And hi, Tanya. I hope you're well. I think one of the major things about all of this is giving back. And as part of all of this, I'm going through more cases. I'm learning more. Yeah. I'm growing more. And I think if we can all come together as a profession, as opposed to, oh, I'm better than you and this and that. I think if we come together, we're far more likely to get through this as a struggle and succeed. Thank you, Karen. I hope as well. Do you use DSD for composite smile makeovers? Possibly, yes, because that will judge the wax up that I propose that the technician should use. So
wax up is a whole other topic. That's a whole huge topic. Wax.
I mean, we could do that for an hour next time. I'm happy to go through wax ups because it's really, really important. Thank you, Abu Bakr. I hope you're well. But yeah, like I said, it was just a very whistle-stop tour about what we can do. A dental journey. Thank you so much. I think there's so many variables that you start taking into account. I mean, we took so much longer on that first case than we expected because there's so much. Now that aesthetics, what's my polishing protocol? Hi, Dr. Bansal, Joe Bansal. So for everyone who's watching, Joe Bansal, I was his nurse. I was his nurse back in 2007. Yeah, I was his nurse.
Clinical partners, bro.
Yeah, I'll tell you what, Joe Bansal, one of the best aesthetic dentists in the UK, if not the world. So
Joe, hit me up. We'll do a session.
Yeah, Joe. Definitely. So my polishing protocol, I'll tell you what, I'll do a post on my professional page about this today or tomorrow. Basically, I use a combination of Softlex discs, Astropol silicone polishing points. I use the 3M polishing spirals, and I'll finally finish up with a Cosmodent FlexiBuff with some diamond polishing paste. So that was a quick thing. But I've got some slides that shows £10 in the post. No worries, mate. Oh, come on, I'm worth more than that, Joe. Oh dear. But yeah, more than anything, I hope that all makes sense for everyone. I hope that we all can grow and learn together. And like I said, use this time to grow. Use this time to really become better as a clinician, up your knowledge, practice. I mean, I've got some videos coming through next week, which I've done, which I've been practicing on models, or I've been restoring teeth on models, because you know what? I feel I can learn as well.
Guys, I hope you really enjoyed Shiraz's kind of cases that we've gone through there. You've got a few more bits and pieces coming up this week alone, haven't you? So
yeah, that's right. So we've got ortho restorative interface with Tiff Qureshi tomorrow. That's at 7 p.m. And I've got another lecture with Action. So this is a morning one. It's 10 a.m. Thank you so much, Polydenti. I hope you're well. You stay safe as well. Which is going to be hot tips on minimally invasive dentistry and photography. And I'll also include, as that lovely lady requested, my polishing protocol. What was her name? Not Dr. Amitha. It was Nava Aesthetics. On Friday at 10 a.m. I'll go through my polishing protocol on the slides so that you can understand that more appropriately. So yeah, I'm just here to give back as much as I can. And again, thank you so much for the invitation. I really appreciate it.
Yeah, no, I've been thinking to get you on for a while, and this whole situation's been the perfect time to get all these amazing clinicians on to speak to us about their work. On Dentistsofinsta, we've got a full schedule for you guys. So tomorrow alone, we've got Dr. Rizal Rizki from Malaysia, Jakarta. Is that Malaysia?
Cool.
It's Malaysia.
Yeah, yeah.
He's amazing. 2 p.m. for that one, guys. Have a little look at his page, and I can't even express how good that guy is at what he does. And then in
He's
the
amazing.
evening, we've got the Queen of Invisalign. That's Christina Blatcher from Texas, I believe. So she's going to talk to us all about all things Invisalign, doing similar to what Shiraz has done, gone through some of her actual cases and the thought process behind everything, precision attachments, little bits and pieces along those lines.
Great.
On Thursday, we have Nat Bradley going to talk to us about special care dentistry and probably a bit about COVID, because she's been involved in some of the bits and pieces in London. In the evening, we have Stefan Decker on lingual braces. Friday is a little up in the air at the moment. On Saturday, we have someone who's going to talk to us about, I can't remember Saturday. I can't remember who Saturday was. It was really good,
I
but
think the